Good morning, good afternoon, and good evening, everyone. I'm Mukta Sandhu, Senior Scientific Education Manager from Geistlich Pharma, Switzerland. I am very happy to announce that we have a duo pair from Scotland, a very, very interesting kind of a webinar we have today about the sinus lift management. We have Dr. Colin Campbell and Dr. Beatriz Sanchez as our speakers today, who will give us a more insight about their daily practice in sinus lift management. Little bit of information about and the introduction of our speakers. Dr. Colin Campbell is a dentist originally from West Coast of Scotland. He graduated from University of Glasgow, and then he became a fellow of Royal College of Surgeons of Edinburgh by examination. Currently, Dr. Campbell is the owner and clinical director of the Campbell Clinic in Nottingham, which is a multidisciplinary specialty practice. He's also a founder and a clinical director of the Campbell Academy, which is an implant education organization based in Campbell Clinic facility in Nottingham. Dr. Campbell has lectured in implant dentistry and oral surgery nationally and internationally around 20 years and provided thousands and thousands of hours of education. On the other hand, Dr. Beatriz Sanchez, she began her studies in Barcelona University in Spain, and then she started developing a special interest in oral surgery. She moved to UK in 2010 to pursue her post-graduation education. She also has been involved in teaching and lecturing in different levels of both practical and theoretical fields, from being an assistant teacher at the University of Barcelona to being awarded at national and international level of congresses. She's a part of Campbell Academy faculty since 2016, and she is heavily involved in teaching and mentoring and program content and development. So I'm very happy to have this duo who's really going to be very enterprising for us. And so enjoy this webinar. Just for our live audience, if you have any questions, we will take them at the end of this webinar. You could write them down in the question box on your right side, and we will be taking them along with our speakers at the end of the webinar. And if you have any technical issue, please don't hesitate to write to us, and my colleague Artem Raskatov would help you out. So enjoy, relax, and have a great time listening to these fantastic speakers. Over to you now.
Thank you very much for the kind invitation. Dear colleagues, it's wonderful to be here. Beatriz and I are hoping to take you through a webinar this evening to introduce you to 10 steps of assessments for sinus patients, for grafting in sinus patients. And we hope that by the end of this webinar, you will have a greater understanding of some of the key features of assessment in sinus grafting.
Yes, the idea is teaching you what to look at when you have a patient that potentially requires sinus lifting, and trying to help you with our experience and the things we look at here in the practice when assessing and looking into these kind of patients.
So, ladies and gentlemen, my name is Colin Campbell. I am a specialist oral surgeon, originally from Scotland, hence the Scottish flag above my face, and am practicing in England at the Campbell Clinic and Campbell Academy in Nottingham.
My name is Beatriz Sanchez. I am Spanish. I have an MSc in dental implants, and I have been here in the UK for 15 years now, and I work in the field of oral surgery and dental implants.
What you'll see through the process of this talk is that if there is a Scottish flag at the start of a sequence of slides, it'll be my turn to discuss the issues associated with sinus grafting, and similarly,
when it's a Spanish flag, it will be me.
So let's go on and begin just chatting about the process that we will go through in assessing patients for sinus grafting. In the first instance, though, we would just like to clear up the conflict of interest issues around CE credits for education. This webinar is sponsored by Geistlich, and Beatriz and I have very luckily both received remuneration from Geistlich for the presentation. But the views and opinions of this are of ours and not necessarily Geistlich, and we have no other conflict of interests in relation to this that we'd like to discuss.
Let me do a little bit of learning objectives. So after completion of this webinar, delegates will be able to understand the process of maxillary sinus elevation using clinical examples with photos and videos. We will also go through 10 areas of assessment for maxillary sinus lift procedures, which allow delegates to perform individual case evaluation. We will also teach you how to recognize potential increase in the difficulty of a case and allow to referral if required. And also we will discuss techniques to facilitate easier implant surgeries and reduce or simplify the sinus elevation procedures.
So let's get started, guys. And I think the best way to begin is to discuss a case with you of this young woman who attended the clinic with a deciduous tooth left in place, and which was soon to be shed. The tooth was lost and she was left with a space in the upper premolar area, which was requiring reconstruction. But on a CBCT assessment of this area, you can see there is almost no residual height available, and there is almost no height for grafting. So the case is planned in a digital fashion. Pay attention, guys, to the lack of height that exists there, but the ability still to place an implant simultaneously. And in a sinus grafting procedure, what we will do is access the area using a standard mucoperiosteal flap, expose this, and then collect material using a bone scraping device, which allows us to collect some of the patient's own bone, some autogenous bone. And you can see then in the video how we start to prepare a window in the lateral wall of the maxilla to access the sinus membrane using a large round burr in this case. Some people will use a piezo surgery unit, depending upon your style of surgery. And you can see then that we very carefully create a window in this area, which will allow us to elevate the membrane and then to raise this up. The large round burr that we use, the diamond burr, allows us to create this window down to the membrane without perforation, and then we use specific instrumentation types. This is called an elephant's foot instrument, which allows very careful elevation of the sinus membrane in the area. And it starts off the process of elevation here. You can see how fragile this is, how sensitive it is to technique. As we start to elevate the membrane away from the wall. That's a close-up view of the elephant's foot, and how it has a large foot aspect on the end of the instrument to allow us to very carefully tease the membrane off the wall. We then use some specific size matched elevation instruments, which allow us to carefully and atraumatically remove the Schneiderian membrane, the sinus membrane, from the floor of the sinus and from the wall of the sinus, creating a cavity in the area and retaining only that very thin residual height which exists on the ridge, which will allow us to achieve implant stability. Previously, people would always look for 5 millimeters of residual height. We have found in our techniques over the past 15 years or more that we can look for much less residual height necessary to place the implant. We would use a surgical guide in this case, in every case. A prosthetic guide to allow a position of this, and then we would start to very carefully create the osteotomy site and just minimally penetrating into the sinus. This also gives us the opportunity here, as we use the prosthetic stent to guide the position of our drill, to gauge the actual biological residual height that's available. We can sense it and feel it in our preparation. So we'll start with a small burr in this, and then we'll continue through the process of preparation here to allow us the opportunity to place the implant. So you'll see here, as we prepare the site with the larger drills, it just drops very carefully into the sinus. We found that there is no need to protect the membrane here as long as you're very careful. We've never had a problem with a tear of the membrane in this. And then the site is prepared with minimal residual height. And then we are able to finalize the membrane position. And at this stage then start the process of grafting the sinus void where the membrane has been lifted to create the bounded cavity within the maxillary sinus. And we use our DBBM, our Bio-Oss material, mixed with about 25% autogenous bone that we've collected from the scraper to fill the cavity and to pack this into the area. Remember that the osteotomy site here is already prepared. And so once the area is packed here, and we don't completely pack this full, we underpack it about 80% to give space for the implant placement. And then we're able to place the implant mechanically into this area and watch the sinus grafting material be pushed out of the buccal aspect of the sinus, and then gain primary stability of the implant into position, which is a key feature we know in long-term implant success. So implant is placed in position, all stable, surrounded by the graft material, and we would always measure the stability of our implant using an ISQ device to measure the implant stability quotient and the rigidity of the implant. And then always the window, the lateral window, is covered with a barrier membrane. We're just applying some water to the membrane there to allow it to be easily handled. The barrier membrane increases survival of implant over time. It avoids fibrous ingress. And then we use a fine monofilament suture to close the area with primary closure to allow the implant site to heal. A postoperative CBCT shows the implant well encased in grafted bone, and a long-term periapical radiograph shows an excellent long-term stable result of the restoration in place, and a great result, even though the residual height was quite low.
Great. So ideally, when we teach and when we show delegates about implant and sinus grafting, I like to follow an implant consultation, all the diagnosis planning, then focusing on the surgery, and then talking about complications, which I think is basic when talking about sinus, because many people are scared of sinus elevation. It's a much more, it's a complex oral surgery procedure, but it's nothing to be scared of. So if you understand the possible complications, if you know how to prevent and how to avoid them, it's something that you can be much more reassured and doing surgery in a much better way. However, because we only have an hour with you today, we are going to focus in the implant consultation and the diagnosis and planning. And we are going to run through 10 different steps to assess a sinus patient. So number one, Colin, you start.
Okay, so back to the Scottish flag. That means it must be back to me. So the first thing that we would think that you would really want to consider when you were assessing a patient is the medical history. And obviously, a medical history for a patient who's suitable for a complex oral surgery procedure, but in particular, sinus pathology. And so in terms of sinus pathology, we would want to ask the patient about any previous history of sinus pathology or sinus problems, including recurrent sinusitis and repeated sinusitis over time. And we would also want to assess this radiographically when we check the patient to see whether there were signs of sinus pathology present. We'll be able to do this by CBCT scan, and in fact, CBCT scans show us a wonderful range of information that allows us to plan cases, but on occasion will show up things in the sinus that we were not expecting. So on the left-hand side of your screen here, you can see a healthy coronal view of a CBCT scan with a minimal membrane present on the right side and a slightly thickened but normally thickened membrane on the left side. The picture that you see in number 2 on the right side of your screen shows a congested sinus, and the key features here are that there are air pockets within the maxillary sinus lining. So we should be concerned about the diagnosis of this. We should reach a correct diagnosis, and we may even in these cases, if we cannot achieve resolution, have to discuss this with our ENT colleagues and further surgery colleagues in order to gain an insight as to whether we can proceed with treatment. In the clinical assessment, we would continue. We obviously look at the patient through a full implant assessment, but one of the things which is particular to sinus grafting is the resorption that we see in the maxilla after loss of teeth, which allows us, it creates a situation where it's necessary for us, without augmentation, to place an implant in a position which is not providing an axial load for the implant. And so an ideal situation will allow the upper implant to strike the lower tooth or lower restoration in the correct orientation. But if that is not present, if we've had lots of resorption on the buccal side of the upper arch, we can see a situation which is very unfavorable from a loading perspective. And so it's very important to assess this potential future interarch position in terms of an ideal implant placement for longevity of the implant over time and to avoid overloading. And so for these cases, they may become more complex. If much bone has been lost, they may need horizontal or even further vertical augmentation of the ridge in order to create the right orientation for the implant to be placed for a long-term stable result.
As number 3, attach gingiva. Because the soft tissue is vital. We all know that we want a thick and a nice band of attached gingiva around our implant restorations. And when we have patients that require sinus lift, usually it's because these cases come with a long-term missing tooth, which has come with a massive bone reabsorption, but also a loss of soft tissue. So sometimes we will require some kind of soft tissue grafting before going ahead with sinus elevation. And sometimes things as easy as designing your incisions and pushing your attached gingiva towards the buccal part and making your exposures rather than your second stage surgery, rather than using a punch and taking away all that important soft tissue, designing an incision that help us to push that tissue towards the buccal part. It's easier in the upper arch because usually we have a very good band of keratinized tissue in the palate, and we have a little bit of movement and a little bit of room to play with that tissue.
And so as we carry on through the assessment process, we want to look at the residual bone height, which I touched on briefly in the video here. Residual bone height is absolutely critical in assessment because it defines what type of sinus graft we might be able to produce or carry out. And so if you see the screenshots of the scan here with an implant in position, if we have greater than 5.5 millimeters of residual bone, we're in a position where we may consider the possibility of a closed sinus lift, a transcrestal lift, as it's known. And in these situations, if we have favorable morphology and a flat sinus floor, it's possible to provide the sinus elevation using a closed technique. The closed technique involves the creation of an osteotomy, but short of the floor of the sinus, and then using size-matched osteotomes to tap the sinus floor upwards, carefully keeping the membrane intact and creating an area on the sinus floor where the membrane is elevated, and then material can be passed into that and an implant placed. You'll see much more of this in the video that Beatriz will present in a few minutes. The open sinus lift procedure is a more complex procedure, a more detailed procedure, which is the video that I showed earlier on. And you can see in these positions, when we have a lack of residual height and we're concerned regarding the ability to achieve primary stability, then we would approach the lateral, the sinus graft from a lateral approach. We would create a window, a Caldwell look window in the buccal aspect at the lateral wall of the sinus, which allows us to access the membrane and elevate the membrane, as I demonstrated in the video. You'll see from the lecture here and from the slides, there are some key measurements that we would look at, which would direct us into this area. But if we're very concerned regarding the ability to place an implant simultaneously, because we have such limited residual height, then it may well be that we will proceed with just a graft on its own and allow an appropriate time for healing, sometimes 9 months, before an implant is placed in the area as a separate procedure. One of the other things that we would want to pay attention to here is also potential septa or walls that are present within the maxillary sinus, which can pass in any direction and are seen on CBCT, because they can restrict the ability to raise the sinus membrane or cause obstructions in raising the sinus membrane and make the procedure more complex than it otherwise is.
I think it's important to highlight as well that this is not about numbers. So not all the cases with the same numbers, with the same residual height are going to work in the same way. And we are not restricted by the residual height. There are other things to take into account, like the patient age, the patient medical history, and the remaining dentition, because all those factors are going to have an influence in the approach we want to use. And being able to provide both and being able to choose what is the best for that particular case is really important. And it's not only about the height, but it's also about the width. And that has a key impact in what we can do. They call me the ridge preservation queen here. And I quite like doing ridge preservation. It's a technique that we have incorporated in the last few years in the practice. And I see that it has massive and very good advantages for treating our patients. Because if we have these two pictures, I know where I prefer placing an implant, and both cases have the same residual height, but it's not about the height, but about the width. In the first image, I have a really good and fat and thick ridge, that is going to make my procedure 100 times easier than the one on the other side, where I will probably have to do a horizontal graft first before doing a vertical and a sinus elevation. And how do we do this? How do we get these cases? So obviously by taking teeth carefully and by ridge preserving at the time of the tooth extraction. So this is a case with a decoronated upper molar. The tooth was clearly unrestorable and the height was limited. I'm not going to win or I'm not going to get any further height by doing a ridge preservation, but what I want in this case is getting as much width as possible and keeping the tissue in the best possible way. And how do we do this? So first of all, we section the tooth and we take the tooth out carefully because there is no point in preserve if we do a mess at the time of extraction. We remove the roots individually. We have quite a good interradicular bone, but the buccal bone was probably quite thin, so that's going to be lost, and we are going to lose volume up to 50% based on the research, but it can be more or less depending on the patient. We will then use some xenograft. I use Bio-Oss collagen. I love the handability of it because I will be able to put it as a block, let it soak with the patient's blood, which is what I want in the socket. I don't want a socket full of biomaterial. I want a socket full of blood, but with the stability that the biomaterial is going to give me on the long term. I pack it to the top, and then I will seal it with a mucograft seal to protect from any food going in and any biomaterial coming out. And then after 4 months of healing, 4 to 6 months of healing, this is what I have. I still don't have enough height to place an implant without any further sinus lifting, but I have a fantastic width to place my implant. And in this case, with this good width and with a flat sinus floor, I'm going to do a closed sinus lift. And how do I do it? So as Colin was mentioning earlier, the basics of a transcrestal, of a closed sinus elevation is prepare your osteotomy short, then using some osteotomes to break the floor of the sinus and lift it up, and then place your implant. And I think we have a video about it, so let me go through it, okay? So this is a patient. He was medical history fit and healthy. He needed an upper right 6 replacement with a slightly limited height, but a really good width. We were only like 2 millimeters within the sinus. So this was a perfect case for a close sinus elevation. So we plan this guided. We plan it to be like 1 millimeter short, and we can control this really, really well with guided surgery. On the older style, it was a little bit more difficult to be not too short, but short enough. With guided surgery, we can control that beautifully. We open the flap. We can see that we have a really nice ridge. We don't need to open any wider flap than that. And then we will start with our sequence, following the prescription, 2 lines, 3 dots, and we are going to start drilling. First with the blue drill, which is the 2.2, the narrow one. And then we start enlarging that osteotomy at 6 millimeters. So we are 1 millimeter short from the floor of the sinus. And then we will enlarge that to the last drill, which is the 3.5. Again, following the prescription, 2 lines, 3 dots. We go through the guide and we check with our pin that we haven't perforated the membrane. At this stage, we are going to use an osteotome. You need to use an osteotome that matches your implant brand because they are going to have the same shape, and you want an osteotome that is concave. And then following the planning, you see where I am. You see that I am 1 millimeter short from the floor of the sinus, and it is there where I am, okay? So I'm going to apply the osteotome. As the camera zoom out, you will see that I'm going to start applying some pressure and tapping the osteotome. This is not the nicest part of the procedure, but it's not too bad. We can use biomaterial. I don't particularly like using biomaterial in my closed sinus lifts because I don't feel that I need it. I feel that my blood clot is going to be stable enough. And because I'm using in cases that are not too challenging, I'm happy with that. But Colin usually uses biomaterial.
Yeah, you do. And we agree to disagree on that, don't we?
And then you can apply your implant through the guide. Again, very predictable, very precise, and very under control. So the implant will lock in position, and then we will be able to assess with the lock sim where we are. Making sure that the implant is fully covered by bone. We will measure the ISQs in this case as well to measure the implant stability. We will suture the area for primary closure. And then as protocol on every sinus case, we take an ultra-low dose CBCT to assess the implant position and making sure that no rough material has passed the membrane because it has been preserved and not well, and all safe.
Moving on through our 10 areas of assessment for sinus grafting, one of the areas which concerns people, at least when they become aware of it as a possibility, is the existence of arterial supplies around the maxilla, which can be interrupted or traumatized during the process of providing a sinus graft. And the posterior superior alveolar artery is the main arterial supply that we should pay attention to in treatment in the posterior maxilla. It can be seen generally quite clearly on a CBCT, as you've seen. It's a branch of the maxillary artery, which obviously is a large feeder branch of the external carotid artery. And it forms one of the three main arterial supplies of the maxilla, including the posterior superior alveolar artery, which is the one we're most interested in, the infraorbital artery, and the greater palatine artery. The latter two should be of little consequence to us in most of our surgical procedures, apart from specific cases, but the posterior superior alveolar artery, and not uncommonly, can become involved in the lateral window preparation for an open sinus lift, and can lead to some interesting times for the surgeon should you become involved in that. And unexpectedly, it can bleed quite a lot. It's nothing to be too scared about as an oral surgeon. I don't want you to think that the patients are likely to lose their life as a result of this. But it is something to be aware of because it's quite dramatic. And so you can see on the coronal approach on the left-hand picture here that there's just a little notch in the lateral wall of the sinus, and that usually denotes where the arterial supply will sit. I like that picture of this because it usually means that the artery is part within the wall, part within the Schneiderian membrane. You'll also see situations where it's completely encased in bone, and that makes it more challenging to deal with when we prepare it for a lateral window approach. I'm going to be given the privilege of explaining and developing one of Beatriz's cases here. This is Beatriz. You'll see the skill she has in sinus grafting procedures, where she's identified the position of the nerve which runs horizontally in the wall.
The artery.
The artery, which runs horizontally in the wall, but then start the process of very carefully isolating that so it does not become ruptured or damaged during the process, after which time it's possible to either tie the vessel off in a standard surgical approach or just to avoid the vessel on what is effectively an arterial bridge here around the sinus grafting procedure. And so you may do that with a handpiece, with the diamond handpiece, or you may wish to do that with a piezo surgery unit in the hope to avoid sort of further traumatic insult on the artery itself. And then having isolated things, we can proceed with the sinus graft procedure as normal with our protocol and to move along to the next step.
So together with the artery, it's also very important to assess how thick that buccal bone is, because that is where we are going to open our window. And it's important that we know if we are working with a really thin paper one that is going to perforate when we are collecting our autogenous bone, or we are actually working with a really thick one that is going to take us a good 20 minutes to open the window. This will dictate the instruments to use and also a little bit our approach. So this clinical case, we have a really thick buccal wall, okay? When I see one of those, I know the opening the window is going to take time because I can never be too sure that how thick one is, and I know it's going to always take me a little bit longer. But that, on the other hand, is a fantastic place to collect our autogenous bone. We are always going to collect it from the buccal wall because that's the only part where we have bone to collect autogenous bone. And this autogenous bone is going to be key for our graft. We want to collect bleeding live parts of a bone with a safe scraper. This is a single-use scraper that is going to allow to very easily collect autogenous material. We will then mix this with our xenograft. We use Bio-Oss large particles because being the sinus a big cavity, we want big particles that allow the blood to go better in between them and create a better scaffold. When we do a contour GBR, we want the small particle because we don't want anything perforating or being too sharp. Yeah. On a sinus graft, we are more happy for bigger particles containing the blood in a slightly different way. So we will mix 25 of autogenous collected from the wall and 75 of our xenograft. Once we have this done, we are going to draw a window. It really helps me to know where I am when I am starting to really. You don't have the best vision when you are doing a window. You need to retract really hard and not losing your landmark and getting your orientation right is really important. It's very easy to tunnel in and starting wide and ending with a smaller window underneath. So if you demarcate and you follow those pathway, I find that it's much easier.
I think that's the biggest risk of a thick wall, isn't it? Mm-hmm. Is that you narrow in and then you end up with a very tiny area of membrane to work with, and you have to concentrate hard to open it out. Right?
We don't advocate for too big grafts. We try to stick to what is necessary, and we don't open massive windows. I know that in other parts of the world, I know in Spain, they tend to do much bigger sinus grafting, but we tend to stick to the size that we need to have to give bone around our future implant. We use pencils that we put through the autoclave, and then you can autoclave a good few times until they start breaking up, but then they are nice and sterile to paint into the patient's bone. This is a little bit material selection. So this is a surgical handpiece that is connected to the irrigation, to the motor. So there is plenty of irrigation. And you will see that there are two different burrs materials. So we have tungsten one and diamond one. If you have a thick wall, you want to start with the tungsten, which is going to be a little bit more aggressive, but it also rattles a little bit more. So you might want to swap to the diamond one once you are getting close to the membrane. You will also see two sizes, a small and a wider one. I like to start small to demarcate my window, but then jump to a large one as soon as possible, because that's going to keep you much safer from perforating the membrane. I have to say that people is scared of perforating the membrane with the handpiece, but it's not the handpiece what perforates the membrane. It's the instrument you use when you are actually raising that pouch and separating the membrane. So I'm not saying that you drill crazy or with your eyes closed, but you can be quite confident in opening that window because it's actually pretty safe. You can see me here opening a window, but you can also see this type of size of windows that we will open for our cases. Having adjacent teeth is always a limitation when opening the window, and that's also something that you can look at. That might be point 11 for next year. So together with the width of the window, so we have already opened the window. Now we are going to start raising the membrane. And as I said, this is actually the most delicate part because some membranes will be thicker, some membranes will be thinner, but also some of them will be much more delicate than others. And you cannot really predict how easy this is going to be. But what you can predict is the shape of the sinus of the floor. Ideally, you want a flat and relatively narrow sinus floor. So if you can see on the upper three images, it's quite flat sinus floor. Raising a membrane and separating and peeling away the membrane is much easier in those cases, comparing with the three in the bottom that you see that it's very bumpy, and raising the flap in any of those, raising the membrane in any of those cases is going to be much more challenging.
Yeah.
Sorry, I'm going backwards. Yeah, sorry. And then together with this is not only about how flat or how bumpy it is, but also how long it is from your buccal wall to your medial wall. So when you are raising your membrane, one of the key things is making sure that you raise the full width and that you travel from the buccal aspect till the medial wall, because otherwise you are quite at risk of only filling half of the cavity. Yeah. We have a magical number here. It's only a number. It's all right if it's a little bit more or a little bit less, but it really helps to have a number in mind when you are doing your consultation. And when you are running through your diagnostic template, you look to that number. That number is 15 millimeters. Anything more than 15 millimeters is going to be challenging, because think how deep your instrument needs to go into a deep hole till reaching that medial wall to raise the full membrane. If you only have 9 or 10, that is much, much easier.
I think that's something that when we were learning sinus grafting, it was something that wasn't talked about. And I think the travel distance, we call it, from the lateral wall to the medial wall definitely makes a difference in the complexity of the case overall. So one of the final things that we'll look at in terms of assessment, and this comes up when we use CBCT to assess sinus grafting patients, and we would recommend that you use CBCT in every single case.
And bilateral, we haven't touched on that.
Yeah, I think that I would always want to see both sinuses in the upper jaw. We have a comparison of the right and left, even if we're only working on one side.
Especially for pathology and for assessing pathology.
It allows us to see the membrane thickness on both sides, doesn't it? But the other thing that will come up in these is sinus septa, which are effectively bony walls within the sinus that you can see, which will increase the complexity of your process and procedure. So you can imagine that depending upon the position of these protuberances, these little areas of wall that emerge within the sinus, which can travel in any direction, it will make it much harder to navigate that or to elevate over that without perforating the membrane. And so understanding where these septa exist, how common they are, and whether or not it's possible to work around them is an essential part of sinus elevation procedure and the skills involved with the assessment and execution of sinus grafting.
Well, and this is all. We have run through the 10 steps. We are going to do a sum up slide. I hope we have given you some good tips and at least like a little bit of a template to follow when you see your next sinus case, and especially if you are starting and you are at the beginning of your career, you find tools to assess the difficulty and not go into cases that are going to be too stressful or too difficult, but at the same time, you can assess those that can be within your competence.
I think we would both want to reiterate that when we learned and moved on to sinus grafting within our surgical careers, it opened up a whole other world of just fantastic work to be able to do. We learned so much more about surgical procedures. It made us better surgeons doing sinus grafting. So if you're thinking about taking the leap, we would recommend that you do take the leap and that you move into this fascinating world of practice. But before we finish, we just take a sinus in front of us here just to reiterate some of the points that we've discussed and things that we look at. One of the first things you would look at in the sinus is it clear or is it full of membrane or fluid? That's a sign of sinus pathology. The second thing we would suggest you look at is how much residual height you have available, because that always tells you something towards the degree of complexity. The third thing we would look at is the thickness of the buccal wall. As we've talked about, that can make the procedure more difficult or more challenging. And the next thing we would look at is the travel distance that we call it between the lateral or buccal wall and the medial wall of the sinus. And we look for less than 15 millimeters ideally. And also whether there is a vessel in the wall or not of the posterior superior alveolar artery, because that will make things more complicated to navigate around. Finally, the shape of the sinus floor. A flat sinus floor with reasonable residual height will give you the opportunity to provide a transcrestal approach with or without material. But if it's not and more complicated, then you're probably going to be safer providing an open approach. So I think that is all of the hot tips. And at the end, I think Beatriz is going to finish off here. I'm sad to say, ladies and gentlemen, I've had just a quick message while we've been doing this, and I have been called to see a patient urgently. So we're going into a question and answer session now, but I know that you will be absolutely delighted to take that on for us.
Yes,
and thank you very much for your help. So I will say my goodbyes. Thank you very much for your time. I hope that was helpful, and we'll see you soon.
Yes, thank you very much. And I will be ready to answer any questions you may have now.